Welcome back to the Deep Dive. Today we are focusing our lens pun absolutely intended on one of the most sophisticated pieces of biological engineering in the known universe.
We are talking about something that can process millions of bits of data per second.
Adjust focus in milliseconds. Distinguish between millions of colors. It's incredible.
And yet, it's arguably one of the most unforgiving structures in the human body when things go wrong. It's a real paradox of strength and fragility.
We are talking, of course, about the eye. But we aren't just doing a surface-level scan today. We are deconstructing the eye, the orbit, and the myriad of pathologies that can afflict it, based on the definitive guide for surgeons.
That would be Baily and Love's Short Practice of Surgery, 28th edition.
Specifically, Chapter 49, titled The Eye in Orbit.
Chapter 49 is, it's a beast of a chapter. For anyone in the medical field, specifically surgery, or, just for those who want to understand the machinery of their own vision, this is the foundational text.
It really is. It covers everything from the basic anatomy to the catastrophic traumas.
And before we jump in, I want to set the stage a bit. I was reading through this, and the image that kept coming to my mind was that the eye is essentially a high-fidelity camera made of, jelly and collagen?
Yeah, that's a good way to put it.
It houses the most sensitive nerve tissue we have, the retina, and we've basically placed it inside a bony cave, the orbit, but left the front lens completely exposed to the elements.
It is a precarious design. It's brilliant, evolutionary perfection in terms of optics, but structurally,
it's vulnerable.
Totally vulnerable. And that's really the theme of this deep dive, isn't it?
Yeah.
We are going to examine the hardware, the anatomy, and then we're going to look at the glitches, the accidents, and the system failures.
A quick disclaimer before we start.
Yes.
Our mission here is to provide an interpretation. Think of this as your ready reckoner or a revision companion. We aren't just reading the book to you.
No. Absolutely not. We want to give you the anchors, the metaphors, and the red flags that will help this dense material actually stick in your brain.
Precisely. If you are a medical student prepping for exams or a clinician with a patient in front of you, you need these concepts to be second nature. But please
go back and read the actual chapter in Baily and Love.
The diagrams, specifically the cross-sections of the orbit and the photos of the pathologies, like the dendritic ulcer, are indispensable. You need to see them to believe them.
Consider this the trailer for the movie, or maybe the director's commentary. So let's look at the roadmap. We're going to start with the fortress itself, the anatomy.
Mm-hmm.
Then we'll move to the lumps and bumps, basically the external exam. We've got a section on the silent threats, intraocular tumors.
And then the trauma ward.
Yes, the trauma ward, with some fictional case studies I've cooked up to test your knowledge.
Oh, good. And we will finish with the red-eye detective work, which is probably the most common clinical scenario a general practitioner will face. It's high-stakes detective work.
Okay, let's do it. Let's get into the hardware. Section 1. The fortress. The orbit. Now, when I look at a skull of the eye socket, it just looks like a simple hole. But mechanically speaking, the orbit is described as a four-sided pyramid.
That's right. Ideally, it's a pyramid with the apex pointing backward into the skull and the base opening onto the face. But it's not an empty room.
No.
It's incredibly crowded in there. You don't just have the globe. You have the optic nerve, the lacrimal gland, and the crew that moves the eye.
The crew being the muscles. I think most people imagine the eye just swiveling on a simple ball joint, like a joystick or something.
Right.
But looking at the diagram in Baily and Love, it's much more industrial than that. It's a whole system of pulleys and countertensions.
It really is. You have 6 extraocular muscles controlling the globe. You have the 4 rectus muscles, which is Latin for straight, and they pull the eye up, down, left, and right.
Okay, that's the intuitive.
But then you have the 2 obliques, the superior and inferior oblique.
The superior oblique, that's the one that caught my attention. It seems to have a very strange mechanical routing.
It's one of the weirdest designs in the human body. The superior oblique muscle runs forward along the wall of the orbit, but instead of attaching directly to the eye, it hooks around this tiny loop of bone and cartilage.
The trochlea.
The trochlea, which literally means pulley. Then it turns sharply backward to attach to the top of the eye. It's using a physical pivot point to change the direction of force.
So it is a literal pulley system inside your head. What is the functional point of that complexity? Why bother?
It allows for torsion. So if you tilt your head to your shoulder, your world doesn't tilt with it, does it?
The horizon stays level.
That's because your eyes are rotating in the sockets in torsion and extorsion to compensate. That's the obliques working in the background. It's essentially biological Steadicam technology.
That explains why the orbit is so packed. You've got these muscles, the fat cushioning them and the nerves driving them, all crammed into this rigid, bony box.
Which becomes a major liability if anything inside that box swells.
Ah. If you bleed or swell inside the orbit, the pressure has nowhere to go but forward, pushing the eye out or inward, crushing the optic nerve. It's a high-pressure compartment waiting to happen.
Protecting the front of this pyramid are the shutters, the eyelids. Now this is where I found the first really cool anchor for memory. Lifting the eyelids seems simple, right? You just open your eyes.
You'd think.
But Baily and Love makes a point to differentiate the muscles involved in that action, and the distinction is, well, it's clinically massive.
It's a classic exam distinction. The main heavy lifter is the levator muscle. That's powered by cranial nerve third, the oculomotor nerve.
Right.
That does the bulk of the work of opening your eye. If you lose that nerve, the eye shuts completely.
But it has a backup helper, a sort of fine-tuner.
It does, Mueller's muscle. But here's the key. Mueller's muscle isn't powered by a cranial nerve in the standard sense. It's sympathetically innervated.
Part of your fight-or-flight wiring. Exactly. It makes perfect evolutionary sense. If you were startled, fight or flight, your eyes widen. That's Mueller's muscle kicking in to give you that extra field of view.
And this leads to a very specific diagnostic clue. The text mentions that if you have paralysis of Mueller's muscle, you don't get a fully closed eye. You get a subtle droop.
A 2-millimeter embetosis.
Just 2 millimeter.
Right. This is the hallmark of Horner syndrome. If you see a patient with a massive, fully closed droop, that's likely a cranial nerve third palsy affecting the levator, but a subtle 2-millimeter droop.
That suggests the sympathetic chain is damaged.
Yeah. You need to look for lung tumors or carotid artery dissections, things that hit the sympathetic nerves in the neck.
So big droop equals nerve palsy. Tiny droop equals a sympathetic problem. That is exactly the kind of nuance we need. Okay, let's talk plumbing. The drainage system. I think everyone knows that crying makes your nose run, but I never really traced the path until reading this chapter.
It is a gravity-fed irrigation system. The lacrimal gland sits up under the upper outer orbital rim. It produces tears, which are swept across the eye by the lids.
Like windshield wipers.
Exactly like windshield wipers. They head toward the nose, into the puncta, those tiny holes you can see in the corners of your lids, then through the canaliculi into the lacrimal sac.
And from the sac.
Down the nasolacrimal duct and dumping right into the nose, specifically the inferior meatus. That's the anatomical connection.
Well, if that duct gets blocked, which happens often in babies or elderly people, you get a watery eye because the drain is clogged.
The drain is clogged. Simple as that.
Incredible. Okay, let's move to the star of the show. The globe, the camera itself. Baily and Love breaks it down into layers. We have the cornea, the window.
The 12-millimeter window. And the text makes an interesting point about why the cornea is clear. It's not just clear tissue. It's clear because of a very specific arrangement of collagen bundles, and this is crucial dehydration.
Dehydration. I would have thought it needs to be wet.
The surface needs to be wet, yes, but the stroma, the meat of the cornea, needs to be kept dry. There are pumps on the back of the cornea that actively pump fluid out of it.
Oh, I see.
If those pumps fail, or if the pressure in the eye gets too high, fluid forces its way in, the cornea swells and it turns cloudy.
Like frosted glass.
Exactly. That explains why hazy cornea is such a bad sign. It means the pump system is failing or it's overwhelmed.
And holding the shape is the sclera, the white chassis.
Which is 4/5 of the wall. It's tough, fibrous protection.
And inside we have the film processing center, the retina.
Photoreceptors to ganglion cells, sending all that data down the optic nerve. But to keep this camera inflated, you need pressure. This brings us to intraocular pressure, or IOP.
This balance fascinated me. It's a constant flow, isn't it? It's not a static balloon.
Not at all. It's dynamic. You have the ciliary processes producing fluid aqueous humor, which hydrates the lens and cornea, but that fluid has to leave. It drains through the trabecular meshwork into Schlemm's canal.
So think of it as a sink with the tap constantly running.
That's a perfect analogy. The drain, the trabecular meshwork, has to be open. If the drain clogs or if something covers the drain, the sink overflows. But since the eye is a closed sphere, it doesn't overflow. The pressure spikes.
And the magic number is?
The normal range is 10 to 21 millirad Hg. Remember that range. Anything above 21 is suspicious. Anything significantly higher can start killing the optic nerve.
Okay, check-in moment number 1. I'm going to put you, our listener, on the spot. Pause if you need to think, based on what we just discussed. If a patient walks in with a slightly drooping eyelid, just a tiny bit, maybe 2 millimeters, which muscle is affected and which part of the nervous system is likely responsible?
Give it a think. The answer is Mueller's muscle. And because it's a subtle droop, it points to a problem with the sympathetic nervous system. You should be thinking about Horner's syndrome.
If you shouted levator muscle, rewind the tape. The levator is the big lifter. If that goes, the eye is shut. Mueller is the subtle adjuster.
It's a vital distinction.
Moving on to section 2. Lumps, bumps, and swellings. This is the external exam. The text lists a few things that can grow around the eye, and some of them are terrifyingly deceptive.
Let's start with dermoid cysts. These are congenital present from birth.
Right.
They usually pop up around fetal suture lines, often the frontozygomatic suture near the eyebrow.
They look innocent enough.
Right.
Just a lump. A parent might bring a child in and say, "Can you just cut this off?"
And that is the trap. They have what the book calls a dumbbell danger. The cyst might look small on the surface, but it can extend deep into the orbit in a dumbbell shape through the bone.
And the text has a very specific warning about removing these. You don't just slice them off in a GP clinic.
Absolutely not. You must CT scan them first. Why? Because these cysts can erode the bone and attach to the dura, the covering of the brain.
Oh, no.
If you go in blindly with a scalpel thinking it's a simple cyst, you could be opening a direct line to the brain lining and causing a CSF leak or meningitis.
That is a high-stakes pimple popper. Always get the scan.
Now, speaking of common lumps, let's talk about the eyelid itself. I feel like everyone confuses styes and chalazions.
It's the most common mix-up in primary care. Let's create an anchor to separate them. A chalazion, or a meibomian cyst, is a blocked oil gland. So it's chronic, it's granulomatous, it's smooth, round, and usually painless.
Just a bump that won't go away because the oil has hardened.
Exactly. Now, a stye, or a hordeolum, is an infected hair follicle. Think stye equals staph and stinging. It's acute, it's angry, it's painful, and it's red. It is an active abscess.
So chalazion is a clogged pipe, stye is an angry infection.
Roughly, yes. For a chalazion, you try hot compresses to melt the oil. If that fails, it's incision and curettage. You flip the lid and scoop it out. For stye, you treat the infection, pull the lash, antibiotics, and heat.
And then there is the lump you absolutely cannot ignore, the rodent ulcer.
Basal cell carcinoma. It's the most common malignant tumor of the eyelid.
Why do they call it a rodent ulcer? That's a visceral name. Because of the appearance. It has raised, pearly, rolled edges with a central ulceration, as if a rat has been gnawing at the skin. It usually happens on the lower lid.
So if you see a pimple that won't heal, ulcerates, and have those rolled edges, especially in an older patient.
Biopsy it. Do not wait.
Got it. Raised edges, lower lid, gnawed look. Now, before we leave the external exam, we have to talk about proptosis bulging eyes. The text says there is one cause that dominates them all.
Thyroid eye disease. It is the most common cause of both unilateral and bilateral proptosis in adults.
I understand how a tumor behind the eye pushes it out. But in thyroid disease, what is physically pushing the eye forward?
It's the muscles themselves. In thyroid eye disease, the immune system attacks the extraocular muscles. They become infiltrated with inflammatory cells and fluid.
So they just swell up.
They swell up. Remember our crowded pyramid. If the muscles swell to 3 times their size, there is no room. The eye is pushed forward out of the socket.
And there's the lifestyle factor mentioned here, too, that acts like fuel on the fire.
Smoking. The disease is significantly, measurably worse in smokers. The risk of severe proptosis and optic nerve compression is much higher.
So if you have a patient with thyroid issues and early bulging eyes, telling them to stop smoking is not just general health advice.
It is a genuine medical intervention to save their sight.
Let's go deeper, literally, into the globe. Section 3, intraocular tumors. These are the silent threats because you can't necessarily see them without looking in.
And we break this down by age. In children, the big one is retinoblastoma.
This one scares me. What are we looking for?
You're looking for leukocoria. That's the clinical term for a white pupillary reflex. You know when you take a flash photo and you get red eye?
Yeah.
That's healthy. That's the retina reflecting light. If you take a photo of a child and one pupil reflects white like a cat's eye, that is a major red flag.
It looks like there is something white sitting inside the eye.
Exactly. It's the tumor mass reflecting the light. Or sometimes the child develops a squint, a strabismus, because they can't see out of that eye to focus it.
And the text is very firm on this.
Any child with a white pupil needs an ophthalmologist immediately, not next week. Now.
And the genetics are interesting here.
It involves the RB1 gene on chromosome 13. About 40 to 50% of cases are hereditary and autosomal dominant. So if a parent had it, the child is at high risk.
Okay, so white pupil in a kid equals retinoblastoma until proven otherwise. What about adults?
In adults, the most common primary malignant eye tumor is malignant melanoma. It starts in the choroid, ciliary body, or iris.
There was a phrase in the text that I underlined twice. It was a warning. Beware the patient with a glass eye and an enlarged liver.
It's a chilling medical aphorism. It highlights the behavior of ocular melanoma. It has a nasty habit of metastasizing to the liver, but it can do so after a very long delay, sometimes 10, 15, or even 20 years later.
So a patient might have had an eye removed a decade ago for a problem they barely remember and now presents with liver failure.
Exactly. And unless you ask about the glass eye or notice the prosthetic, you might miss the primary source. You have to connect those dots.
Beware the patient with a glass eye and an enlarged liver. That is going to stick with me.
As it should.
Okay, moving on to section 4, the trauma ward. I've written up 3 scenarios based on the injuries described in Baily and Love. I want you to walk us through the mechanics of what's happening in each.
I'm ready.
Scenario A. We have a squash player. He turns around and takes a ball, traveling at high speed, directly to the eye socket. It's blunt trauma. He comes in with a black eye. His eye looks a bit sunken, in ophthalmos, and he complains that his cheek feels numb.
Okay.
But here is the kicker. When you ask him to look up, he sees double.
This is a classic textbook presentation. This is a blowout fracture.
Let's deconstruct it. Why does the floor break if the ball hits the eye?
It's the hydraulic theory. A squash ball is slightly larger than the eyeball, but smaller than the bony rim. When it hits the soft tissue, it seals the orbit and compresses the globe.
And the eye is filled with fluid.
Yeah.
It's incompressible.
Exactly. So the pressure inside the socket spikes instantly. It's a pressure bomb, and that force has to escape somewhere.
And the orbital floor is the weakest wall.
Paper-thin bones separating the eye from the maxillary sinus. The pressure blows out that floor like a trap door.
So the floor shatters downward, and that explains the sunken eye. The contents have dropped into the basement. But why the double vision looking up?
Because sitting right on that floor is the inferior rectus muscle. When the floor shatters, the muscle can get caught on the jagged bone edges or entrapped in the tissue.
It's physically tethered.
It's tethered. So when the brain says look up, the muscle can't stretch. The eye stays down. The other eye looks up. Result: vertical diplopia.
And the numbness.
The infraorbital nerve runs in a groove right along that floor. When the floor breaks, the nerve gets damaged or stunned, causing numbness over the cheek and upper lip.
So sunken eye, numbness, can't look up, blowout fracture.
Oh, scenario B.
We have 2 patients with burns. Patient 1 is a welder who wasn't wearing his mask. He felt fine at work, went home, had dinner, but wakes up at 2 a.m. in agony, feeling like he has sand in his eyes. Patient 2 is a lab tech who splashed a cleaning solution in her eye.
2 very different mechanisms. The welder has arc eye or snow blindness. It's a radiation burn from UV light.
And the key feature is the delay.
The delay. It takes 6 to 12 hours for the epithelial cells on the cornea to die and slaw off, exposing the nerves. That's why he wakes up at 2 a.m. screaming.
It sounds horrific, but is it permanent?
Usually not. It heals rapidly, often in 24 to 48 hours with antibiotics and lubrication. The lab tech, however, is in much more danger. This is a chemical burn.
And here the chemical matters. Baily and Love is explicit. Alkali burns are worse than acid burns. I would have assumed acid is worse. It sounds more destructive.
Most people do. But think about the chemistry. Acid causes proteins to coagulate. It cooks the surface. This forms a barrier of dead tissue and Escher that actually stops the acid from penetrating deeper.
It seals itself off.
Right. But alkali like lye, drain cleaner, or lime causes liquefactive necrosis. It saponifies the fats in the cell walls. It essentially melts through the tissues. There is no barrier formed.
It just keeps going.
It penetrates the cornea, enters the anterior chamber, and destroys the lens and internal structures within minutes.
So what is the immediate action for the lab tech?
Irrigation, copious irrigation. Do not wait for an ambulance. Do not look for an antidote. You verify the pH if you can, but primarily you wash that eye with liters of saline or water until the pH returns to neutral. Time is vision.
Scenario C. This one is a car accident victim, smashed windshield. The patient is conscious, but when you look at their eye with a pen light, the pupil isn't round. It's irregular, teardrop shaped, pointing toward a cut on the cornea.
Stop. Put the pen light away. Do not pass go. Do not touch that eye.
Why?
An irregular pupil in the context of trauma is the hallmark of a penetrating injury. The iris acts like a plug in a bathtub. If there is a hole in the cornea, the fluid rushes out and the iris gets sucked into the wound.
And that pulls the pupil into that teardrop shape pointing at the injury.
Yes. And the reason you don't touch it is because the eye has been perforated. The structural integrity is gone. If you try to pry the swollen eyelids open to get a better look, or if you press on the eye to check the pressure,
You could squeeze the contents out.
you might squeeze the contents of the eye, the iris, the lens, the vitreous out through the wound. You could turn a repairable injury into a lost eye.
That is a terrifying thought.
Yeah.
So shield it and wait for anesthesia.
Exactly. Put a rigid shield over the eye resting on the bony rim, not the soft tissue start antibiotics, and examine it under general anesthesia where you have control and the patient isn't squeezing.
Also, a stat from the text. Seat belts reduced these specific windshield injuries by 73% in the UK.
It's one of the great public health victories.
Okay, check-in moment 2. Let's revisit scenario A. You have a patient with a black eye who sees double when they look up. Which wall of the orbit is broken and which muscle is trapped?
Think back to the squash player. It's the orbital floor, the weakest wall, and the trapped muscle is the inferior rectus.
If you said roof and superior rectus, visualize gravity. The floor breaks, the contents drop.
Right. Let's move to the most common puzzle you'll solve. The red eye.
Section 5. The red eye detective. The text lays this out as a differential diagnosis. You have to be a detective because red eye can mean anything from I sneeze too hard to I'm going blind in an hour.
We can categorize them. It's a decision tree. Let's start with the harmless red, subconjunctival hemorrhage.
This looks dramatic, though. Bright red blood covering the white of the eye. It looks like something out of a horror movie.
It looks terrible, but notice what isn't there. Pain. The patient feels fine. Vision is normal. It's basically a bruise under the clear skin of the eye.
So usually from coughing, sneezing, or straining.
Exactly. It resolves on its own. Reassurance is the treatment.
Then we have the itchy and sticky group, conjunctivitis. This is where the history is key.
Right. You need to distinguish the source. Bacterial is all about pus. Purulent, sticky discharge. The eyelids are glued together in the morning. Viral is watery. The eye is red and watering profusely, and allergic is the itch. The patient is rubbing their eyes.
For viral conjunctivitis, the text mentions a specific physical sign you can check for outside the eye.
Yes, the preocular lymph node. Feel right in front of the ear. If there is a tender, palpable little bump there, it's almost certainly viral, probably adenovirus. Bacteria rarely cause that node to swell.
That's a great tip.
It's a great Blinkist tip for rapid diagnosis.
Now let's cross the line into the dangerous red. The text highlights keratitis, or corneal inflammation, and specifically herpes simplex.
This is a critical section. Herpes simplex keratitis presents as a dendritic ulcer. If you put fluorescein dye in the eye and look under blue light, you see a branching tree-like pattern on the cornea.
Like a little lightning bolt or a tree branch.
Exactly. And there is a massive warning here. If you see that tree branch, what must you never do?
Never give steroid drops.
Never.
Why? Steroids reduce inflammation, right?
Hmm.
That sounds like a good thing.
In this specific case, it's catastrophic. Steroids suppress the local immune response. The herpes virus loves that. If you give steroids, the virus replicates wildly. That tiny tree branch ulcer spreads out to become a massive geographic ulcer, so-called, because it looks like a map.
And it can scar the cornea permanently.
Permanently. So, dendritic ulcer, no steroids. Period.
Now, let's talk about the true emergency. Acute angle closure glaucoma. This is the one that can fool you because it mimics a stomach bug.
Yes. The pressure in the eye rises so high and so fast from 15 to maybe 60 millimillig that the pain triggers a massive vagal response. The patient might be vomiting, sweating, and have a severe headache.
So you could focus on the vomiting and think food poisoning and miss the eye completely.
It happens all the time, so you have to look at the eye. What does it look like?
The cornea is hazy or steamy.
Right, because the high pressure has forced fluid into it. The eye feels rock hard to the touch, like a marble compared to a grape. And the pupil. It is fixed in a mid-dilated position and is oval.
Why oval?
Because the high pressure paralyzes the sphincter muscle of the iris and sectors, usually leaving it vertically oval.
So pain plus vomiting plus hazy eye plus oval pupil.
That is acute glaucoma. You need to lower that pressure immediately. We use a kitchen sink approach. Pilocarpine drops to constrict the pupil, acetazolamide to stop fluid production, maybe IV mannitol to dehydrate the eye.
And then a more permanent fix.
Once the pressure is down, they need a laser iridotomy, basically poking a hole in the iris to create a bypass valve. It's a plumbing emergency.
Oh, plumbing emergency. I like that. Let's switch gears to Section 6, painless vision loss. The patient isn't in pain, but the lights are going out.
We divide this into sudden and chronic. Chronic is your cataracts, cloudy lens, chronic glaucoma, the silent thief of sight, and macular degeneration. These are slow fades.
But sudden painless loss, that's usually vascular.
Right. Think of it as a stroke of the eye. Central retinal artery occlusion, the lights go out instantly. Or retinal detachment, which patients often describe as a curtain coming down, often preceded by flashing lights and floaters.
But there is one, do not miss diagnosis in this section, a medical emergency that presents as vision loss in the elderly.
Temporal arteritis, or giant cell arteritis.
This is a systemic vasculitis, right?
Yes, the arteries in the head become inflamed. If the inflammation hits the artery supplying the optic nerve, the nerve dies. You go blind instantly and permanently.
What are the clues? Because the eye itself might look normal at first glance.
The patient is elderly, usually over 60. They have sudden visual loss, but you have to ask the specific questions. Do you have a headache? Does your scalp hurt when you brush your hair?
The Combs sign.
Scalp tenderness. Also, jaw claudication. Pain in the jaw muscles when chewing meat or talking. That means the arteries supplying the jaw are also inflamed.
And if you suspect it,
you don't wait for the biopsy. You check their inflammatory markers. ESR and CRP will be sky high, and you start high-dose steroids immediately. You are racing to save the other eye. Usually the vision in the first eye is gone and cannot be recovered, but the second eye is at imminent risk.
That is intense. Combs sign plus vision loss equals emergency steroids. Finally, Section 7, the surgical toolkit. We've hinted at some surgeries, but how has eye surgery evolved?
It's gone micro. Cataract surgery used to involve large incisions and weeks of recovery. Now we use phacoemulsification.
A great Scrabble word.
It is. We use an ultrasound probe to vibrate the cloudy lens into tiny fragments, emulsifying it, and suck it out through a tiny 2 or 3 millimeter incision.
And then you just slide in a new lens.
We slide in a foldable plastic lens that pops open inside the eye. It's elegant engineering.
And for glaucoma.
Traditionally, we do a trabeculectomy, creating a little trapdoor or fistula in the sclera for fluid to drain out under the conjunctiva.
Right.
But now we have MIGS, minimally invasive glaucoma surgery.
Using microscopic shunts and stents.
Exactly. They look like tiny snorkels to bypass the blockage.
I want to end this section on a distinction that I didn't know existed, and the reasoning is fascinating. The difference between enucleation and evisceration. They both sound like removing the eye.
But they are very different procedures for very different problems.
So enucleation is?
Enucleation is the removal of the entire globe. You cut the muscles, cut the optic nerve, and take the whole eyeball out intact. You do this for tumors like melanoma or retinoblastoma.
Because you need clear margins. You don't want to cut into the cancer.
Exactly. But evisceration is, well, it's scooping out the contents. You make a cut in the front, remove the cornea, and scoop out the iris, retina, and vitreous. You leave the white shell, the sclera, and the muscle attachments behind.
And then you put an implant inside that shell. Why would you leave the shell?
2 reasons. 1, cosmetic. The muscles are still attached to the shell, so the prosthetic eye moves much better. But the second reason is a critical safety rule regarding endophthalmitis.
Which is a severe infection inside the eye. A pus-filled eye.
Right. If an eye is full of aggressive bacteria and pus, you do not want to perform an enucleation. Because when you cut the optic nerve during enucleation, you are cutting across the meningeal sheath that surrounds the nerve. And that sheath communicates directly with the subarachnoid space of the brain.
Oh, I see.
If you cut across that sheath in a pus-filled orbit, you risk spreading that bacteria directly into the spinal fluid and brain. You can cause fatal meningitis.
So for a hot infected eye, you eviscerate.
You scoop it out, leaving the scleral barrier intact to protect the brain.
That is a critical safety distinction. Enucleate for tumors, eviscerate for infection.
Precisely.
We have covered a lot of ground, from the bony pyramid of the orbit to the delicate drainage of the trabecular meshwork. Let's recap the big anchors for our listeners.
Okay, number 1. The oval, irregular pupil. Suspect penetrating trauma with iris prolapse. Do not touch.
Number 2. The white pupil in a child. Leukocoria. Suspect retinoblastoma. Immediate referral.
3. Pain plus vomiting plus hazy eye. That's acute angle closure glaucoma.
4. Dendritic ulcer. That's herpes simplex. No steroids or you'll cause geographic scarring.
And 5. The 2 millimeter proptosis. That's Miller's muscle. Think Horner syndrome.
And the Combs sign for temporal arteritis. Don't forget that one.
Absolutely.
I want to leave our listeners with one final thought from the chapter that blew my mind. We talked about corneal grafts, but what happens when a patient's cornea is so damaged, maybe from a severe chemical burn, that a normal donor graft won't work?
Ah.
The body just rejects it or the surface is too dry.
You're talking about the osteoodontokeratoper prosthesis.
The name alone is a mouthful.
It's commonly called tooth and eye surgery. It's a procedure of last resort mentioned in the text.
Explain how this works, because it sounds like science fiction.
If you put a plastic artificial cornea directly into the eye, the body will eventually extrude it, push it out, because it doesn't bond with the plastic. But the body doesn't reject its own tooth.
Okay.
So surgeons remove one of the patient's canine teeth, along with the surrounding bone and ligament.
They take the whole tooth out.
The whole complex. They shave the tooth down into a flat plate, a lamina. They drill a hole through the middle of the tooth and glue a plastic optical cylinder into that hole.
A plastic lens.
A plastic lens. Then they implant this tooth-bone plastic complex into the patient's cheek for a few months to grow a blood supply.
And
Then they transplant it into the eye. The plastic lens lets them see, but the tooth acts as the frame. The body accepts the tooth because of the periodontal ligament, creating a biological seal that prevents infection and rejection.
so the patient is literally looking through a hole drilled in their own tooth.
They are. It highlights that surgery is ultimately about improvisation. We use the materials we have, collagen, bone, even teeth to restore function. The eye is a camera, yes, but repairing it sometimes requires being a carpenter.
That is a wild image to end on. If you want to see the dendritic ulcer, the blowout fracture, or diagrams of that pulley system we talked about, open up Baily and Love, Chapter 49. The visuals really cement the knowledge.
Indeed. Go look at the pictures.
Thanks for diving deep with us. We'll see you in the next deep dive.